Bisa dimulai ya.
Baik dokter, silakan dokter. Nanti yang memberikan sambutan dari dokter Anita ya dokter.
Dokter Anita. Oke, baik.
Terima kasih banyak dokter.
Iya, mari sama-sama. Baik, selamat pagi kepada yang terhormat Dr. Anita dari mewakili Gracia Jaya, dari GCM. Kemudian Dr. Asis Sodi. Good morning, Doctor. Thank you for the time for our information today. Dan selamat pagi kepada mahasiswa semuanya yang mengikuti seminar ini. Mohon diperhatikan dengan baik karena ini sangat bermanfaat sekali untuk kalian, terutama yang koas ya. Baik, sebelum kita mulai, saya berikan kesempatan dulu kepada Dr. Anita dari GMC untuk memberikan sambutan. Silakan kepada Dr. Anita.
Selamat pagi, Dokter Gusti Ayu Vina. Terima kasih atas hari ini. Terima kasih kepada Universitas Udayana atas waktu dan kesempatannya hari ini. Kami diberikan kesempatan untuk memberikan sharing mengenai ilmu restoratif update dari KER. Saya harap mudah-mudahan kegiatan hari ini dapat memberikan manfaat dan berguna bagi kita semua. Terima kasih.
Baik, selanjutnya saya akan bacakan dulu ini CV-nya ya. Dr. Asis Sodi adalah seorang product manager dari Kavo Care. Beliau adalah dari support APAC region, itu manajemen care restoratif endodontik. Kemudian seorang profesional dokter gigi yang postgraduate-nya healthcare management. Dr. Asis Sodi, for the time and the place, please.
Thank you so much, Dr. Krusty. Good morning, everyone. My name is Asis, and thanks for the introduction. I am the product manager for APAC region at KavoCare, and today in this session, we are looking to share with you the innovations, the latest innovations in aesthetic composites. And the idea is to help you understand what is the science and what is the innovation that is there in the market, as well as how can this be used to improve your clinical practice. So in the presentation, I will also be sharing some clinical tips and tricks that can help you, again, achieve clinical success using these products as well. So we also have our KavoCare team here, as well as Russia, that is our distributor. So thanks everyone for joining in. So I will get into the details of the presentation now. Okay. So the very first slide, what it really shows is a beautiful smile, right? So these days in the current world that we are living in, patients want a beautiful smile. Nobody walks into a dentist's clinic and asks for an amalgam restoration or a gold restoration. Patients are looking for tooth-colored restorations, aesthetic smiles, aesthetic restorations. And that is the reason why there is development and there is innovation on tooth-colored restorative materials, which are primarily your composite materials. Right, so for any restoration, the very first step is adhesion. So we are going to talk in detail about the basics of adhesion. Adhesion by far is the most studied science in restorative dentistry, and you will also hear from your faculty and other clinicians in the market that adhesion is also a difficult step to do right. So it's very important to understand what are the different components and what is the science behind adhesion and how the products that are available can help you achieve a good bond. Okay, so for that, let's just get an overview of the anatomy of our enamel and dentine. Now, as we know, enamel composition, if you look at your enamel here, it is highly mineralized. It is the hardest substance in the body. It is 96% mineral, which means that it is very, very hard, right? Because the inorganic component is pretty high. So in order to be able to bond to enamel, in order to be able to etch enamel, we need to dissolve the inorganic component, for which we need an acid. So we use phosphoric acid. Usually enamel etching is the first step that any doctor would undergo in order to initiate their adhesion protocol. For enamel etching, we would use phosphoric acid, which helps you to remove the crystals as well as the inorganic components of enamel from the surface and makes it rough. So the roughening of the surface helps in actually the micromechanical bond that is formed between the composite, the bond, and the enamel. So we etch the enamel in order to enhance the micromechanical bond. This layer that we remove can be about 10 microns in thickness. So when we're using phosphoric acid, this technique is usually called a total etch technique. Now, when we are using a total etch technique, we are using a phosphoric acid on the enamel surface. What has happened on the enamel surface? Now, this first image that you have here, it is an SEM image. You can very easily appreciate that the surface here is pretty irregular. That means that the etch pattern is pretty strong. So the surface is not smooth. Whatever you apply on top of it will have a mechanical retention. It will have a micromechanical bond formation because the surface has been made irregular by enamel etching. So the bonding agent that is applied on the surface will be able to lock into the surface here because of the micromechanical bonding. Now, when we use a self-etch technique, and later in the presentation, I will tell you the differences between total etch and self-etch techniques. Total etch requires you to use bonding agent. Total etch will require you to also use a phosphoric acid. However, a self-etch, as the name suggests, etches on its own. So you don't need to apply a separate phosphoric acid step. So if you look at the enamel bonding or the enamel surface from self-etch, the difference between these two surfaces is easily appreciated. You can see that the surface here at the bottom image is smoother as compared to the image on the top. Now, what that means for you is that the micromechanical locking with self-etch is not as strong as enamel that is etched with phosphoric acid. And we can appreciate with the microspaces that are formed, the irregularity that is formed on the surface of enamel when we use a phosphoric acid versus when we don't use a phosphoric acid, right? And that is the self-etch technique. Okay, so that is what happens on the enamel surface using two different techniques. Now, what is dentine? Dentine, as we can see, is 70% mineral as compared to enamel, which is about 96% mineral. This structure or this component of our tooth is less mineralized. So that means that it is not as hard as enamel, right? So the bonding that happens on dentine is different from how it happens on enamel. Dentine also has organic collagen. It is an alive structure. There are nerve endings coming into the dentinal tubules. So this structure is basically, it is more alive as compared to enamel. And that is why the bonding or the adhesion protocol in dentine is different from the enamel surface. Now, why is dentine bonding, how is it complicated, and why is it also something that we need to look out for? That is because of the dentine morphology. There are dentinal tubules in the dentine. There is formation of sclerotic dentine. As a patient progresses in their age, as they get older, with age, there is more sclerotic dentine which is formed. Now, sclerotic dentine is harder it is more difficult to etch sclerotic dentine as compared to a adolescent dentine, right? And then there is a formation of a smear layer. Now, what is a smear layer? Smear layer, you would have heard in dental school, also read about it in restorative dentistry. Smear layer is basically a byproduct of your cavity preparation. So you prepare the tooth with a burr and handpiece and remove the carious lesion. Now, when you're doing this procedure, a byproduct of the preparation is formed, which basically includes your crystals, your organic substances, water, bacteria, many other inorganic mineral crystals, which are produced during the procedure that form a layer on the surface of your tooth. Now, why is it a problem? Because the surface is on dentin and enamel and it cannot be rinsed away easily. So you cannot just splash water and expect the smear layer to be removed. It is very closely and tightly adhered to the surface of the tooth. And this can complicate bonding because it will not allow a proper contact between the bond and the tooth surface. And we want a deep, strong bond between these two, and smear layer can compromise that bond, which is why it is important to either remove it or modify the smear layer so it is a part of the bond. Now, what is the kind of bonding that happens on dentine? We saw what kind of bonding, micromechanical bonding happens on enamel. Now, on dentine, as I said, it is a more organic structure. It is not as inorganic as you have on the enamel surface. So there are dentinal tubules here, there are collagen fibers here. So what happens is that when you apply a bonding agent on the surface of the dentine, there is intertubular dentin that is demineralized, right? However, there is collagen fiber that remains, and there are micro spaces that are formed because of the intertubular dentin that gets demineralized. So there are empty spaces or micro spaces that are formed. And when you apply the bonding agent here, the bonding agent is applied on here, it percolates into those micro spaces and forms a hybrid layer. And that is the basis of your dentine bond. Now, what is hybrid layer? Again, a term which you will hear a lot in different clinical discussions. Hybrid layer is basically collagen fibers. These are the collagen fibers, as well as your adhesive intertwined. So adhesive is going inside, and there are collagen fibers. So this zone that is formed where there is adhesive, the adhesive that has percolated, as well as the collagen fibers that remain, form a hybrid layer. Okay, so it is not a separate layer. It is basically a zone that is formed when you apply the bonding agent on the etched dentine surface. Okay, so the basic difference of total etch and self etch. Total etch bonding agents, you will require a separate etching step. So this slide here clarifies. You can see a separate etching step in the total etch bonding agents. Total etch is also called etch and rinse. So you will first etch the surface and then bond. In self-etch bonding agents, you only etch with the bonding material. So you don't need to have a separate etching step, meaning you don't need to have a separate phosphoric acid step. And then you will bond. Now, based on the number of bottles that you're using, you can have a two-step technique or a one-step technique, right? So that means if a doctor is a total etch doctor, they want to do a total etch technique, they will etch and rinse, which is your step one. And then based on your bonding agent bottles, they will do bottle one as adhesive and bottle two as bonding. So in total, there would be 3 steps. So the key difference and the key takeaway from this slide is requires doctors to use phosphoric acid. Self-etch does not require doctors to use a phosphoric acid step. Now, this further simplifies what is the difference between the different generations of bonding agents. Now, before I get into the details of this, let me just share some fun fact with you. We read about the first, second, third generation of bonding agents, but just for your information, those bonding agents did not do very well in dentistry. That is why there isn't much literature that you find on first, second, third, and they're not really active in the market anymore. Fourth generation onwards is what we use in the market. Now, what is a fourth generation bonding agent? Fourth generation bonding agent refers to the number of steps that you're going to take to complete the procedure. So fourth generation will require etch, prime, and adhesion. That means you will etch with phosphoric acid, you will prime with bottle 1, and then you will use an adhesive, which is your bond in bottle 2. Right? Now, you will hear a doctor say that I use a fifth generation bonding agent. Okay, so what does that mean for you? That means that the doctor is still following the total etch bonding system. That means they're still etching their surface. However, what they're doing is that they are combining the primer and the adhesive into one. Okay, so there are how many steps here now? There are going to be 2 steps. So the key difference between fourth and fifth generation is the fact that fifth generation requires 2 steps because the primer and the adhesive is in one bottle. However, fourth generation is going to be 3 steps. Okay. Now, fifth generation bonding agents, which are total etch bonding agents, as I shared, the primer and the adhesive is in one bottle. It is a controlled chemistry. Um, The example for this is OptiBond S, which is in the market for about 25 years, very good clinical success rate. This generation bonding will require you to use a phosphoric acid. However, primer and adhesive is in one bottle. So it's primarily 2 steps. There is etch and rinse, and then there is bond and priming in one step. Now, what happens when you're using? Now, we've understood the chemistry of total etch bonding agents. Now, what happens on the tooth surface side? So, if you look at the first image here, this is your enamel. How it's going to look after total etch, after using a total etch technique. This etch pattern is formed because of the fact that we used a phosphoric acid, a very obvious high enamel bond strength that can be achieved with this micromechanical locking. Now, etched dentine is going to look like this. There will be demineralization of intertubular dentine. There will be microspaces that are formed. So these black spots around here are the microspaces. Now, as you apply the bonding agent on top of it, the bonding agent is going to percolate into these microspaces. A very interesting phenomena is post-op sensitivity, which is linked with total etch bonding agents, right? Now, here I want to explain to you why do we say that total etch bonding agents cause or can be linked or related with higher post-op sensitivity. Okay, and this is something that you will hear a lot as you start to practice, and you may have to experience also post-op sensitivity that you've done a restoration, the patient goes back home and maybe calls you in a day and says that they have pain in their teeth, right? They have pain when they drink cold water or something hot. Now, the post-op sensitivity, one of the major reasons of post-op sensitivity can be the technique sensitive nature of total etch bonding agents because of the technique sensitivity involved. Now, what happens on the dental surface when we use a total etch bonding agent is that you're dissolving the intertubular dentine. So you have gaps formed here. And then there is collagen network, which is exposed, right? Now, collagen is like your hair. If the doctor applies a lot of pressure, air pressure on this surface while they're drying the surface after etching it, the collagen fibers can collapse. Now, as the collagen fibers collapse, what's going to happen is that the bonding agent is going to sit on top. So it is going to collapse and sit on top of the dentine surface. It will not percolate. That means that there can be gaps that are left on the dentine surface where the bonding agent has not been able to percolate and seal those gaps. And these nano gaps cause post-op sensitivity, right? So this could be avoided. In a total etch technique, it's important that the doctor does not apply too much pressure while they're drying the dentine surface. And dentine etching is the primary cause of higher post-op sensitivity if the technique that the doctor follows is not correct, right? If they apply a lot of pressure, dry out the dentine too much, that can cause collapsing of the collagen fibers. And then when they apply the bonding agent is not able to penetrate and there are gaps that are formed which can cause post-op sensitivity. So that was a pictorial representation. Now let's look at a SEM image here. This is a moist dentine and this is a dry dentine. A dry dentine is going to look like this in an SEM image. Now, as you're practicing and you're looking into the patient's mouth, how can you tell? What is the clinical indicator? So, dry dentine is going to look very dull, right? A moist dentine should be glossy. So that means that this dentine, the collagen fibers are not very dry. In the moist dentine, the collagen fibers have not dried out. They have not collapsed. They're still pretty available and they're standing and not collapsed, right? So when we apply the bonding agent on top of it, it is going to percolate into the microscope spaces and seal those open gaps. Visually, a clinical tip here for you all is to remember that when you're doing this technique, a total edge technique, always visually check your dentine surface when you dry it. The dentine should be dried so that it looks glossy and moist, not dull. If it looks dull after drying, that means you've applied a lot of pressure and dried it out, right? So you will have to probably make the surface moist. However, if the surface after your drying looks glossy, that means that the dentine is still holding its moisture and it's not over dried. So the key takeaway is that when we are drying the surface of dentine after a use of phosphoric acid, you have to ensure that you don't press too hard and use mild to moderate pressure to dry out the surface so that dentine looks glossy, right? So that is the visual indicator of moist dentine. Okay, so the clinical tip I've already shared. Firstly, make sure that the dentine surface looks glossy when you dry it out with a air syringe, right? So when you're etching enamel, you should etch enamel for at least 15 seconds, right? And realistically, we cannot over etch enamel because it is highly mineralized. So you will not be able to remove all of the minerals. So there is no over etching that is happening. But how about dentine? Just think about dentine surface and the nature of dentine. Can we over etch dentine? Ask yourself. So the answer is that yes, it can be over etched. So the clinical tip here to remember is to follow some guidelines on etching your dentine surface. So I could refer to this study that outlines adolescent dentine, which is younger dentine, softer dentine, should be etched for about 5 seconds. If it is an adult dentine, you want to do 10 seconds. And sclerotic dentine, which is aged dentine, which is older dentine, you can etch for about 15 seconds. And these are the guidelines based on the enamel acid etch review that was published in 2007. Okay, so we've discussed about this slide. We've understood the clinical implication as well as the tips to be able to avoid post-op sensitivity. Now, talking about self-etch bonding agents. One of the reasons for self-etch bonding agents to be in the market is to actually lower the post-op sensitivity, because total edge bonding agents are inherently linked with higher post-op sensitivity because of the nature and the nature of the technique and how technique sensitive the procedure can be with total edge bonding agents. And that is why we came up with self-etch bonding agents. Now, how do self-etch bonding agents help you all? The fact that you are not using a phosphoric acid here helps you to reduce the risk of post-op sensitivity. Now, let me show you how in one slide. Now, just to understand what a sixth generation bonding agent does, you have 3 steps: etch, prime, and adhesive. Your sixth generation bonding agent is going to combine your etch and priming step. So etch and prime is going to happen in one bottle, and then you have adhesive, which is bottle number 2. So a 2-step technique, meaning that you don't need to use a separate phosphoric acid step here. Okay, so now looking at your enamel and dentine. This is what happens to the enamel surface when you're using a self-etch bonding agent. If you could just recall how the enamel looked when we used phosphoric acid, it looked really, the etch pattern is pretty aggressive, right? So aggressive etch pattern gives a higher mechanical retention. Now here the enamel surface looks much more smoother. Okay, so there is reduced enamel etching, lower enamel bond strength. Looking at the dentine, here we are not really washing away the etchant. So how we achieve dentine bonding in a self-etch technique is by modifying the smear layer. Okay, and this technique also lowers the post-op sensitivity chances, the chances of doctors having post-op sensitivity. Now, why is that? Now we saw this image before. These are the dentinal tubules and collagen fibers that get exposed when you're using an etchant. So in a self-etch, you're going to use bottle number 1, which is going to help you etch the surface. Now what happens after bottle number 1 is that the doctor does not need to rinse the surface, meaning that there is no rinsing step involved. That means that the primer or the monomer that has been used to etch the surface is still there, so there are no gaps that are formed which need to be filled. And that is one of the reasons why self-etch bonding agents are linked with much lower post-op sensitivity, because there are no gaps formed as we don't need to wash away the primer. And therefore, these gaps there is no need to fill them up with an adhesive. So no exposure, no nano gaps here. That's the key takeaway. Now, we've understood 4th generation, 5th generation, 6th and 7th. Now, what are the clinical tips for you to follow 6th and 7th generation bonding agents? 6th and 7th generation bonding agents, one of the key tips is to remember that we instrument enamel wherever it is possible. Now, for example, if you look at this clinical image, it is a class 2 cavity. There is enamel on the cavo surface margin. So probably just etching or instrumenting this enamel surface, apply the self-etch primer on dentine, and then allow enough contact time. Follow the manufacturer's recommendations to bond with the bonding agent, and then air dry the solvent. So the key takeaway from here is that you can instrument and etch the enamel wherever it is possible. So you're using phosphoric acid only on the enamel surface. You're not using it all over the tooth surface. And this technique is called selectively etching, a selective etch technique, where you're using self-etch on the dentine, however, phosphoric acid on the enamel surface for increased bond strength. Okay. Now, before we get into more details on composites and some clinical tricks, I want to share with you a clinical tip on immediate dentine sealing. So immediate dentine sealing is also something that is a technique that is followed by many clinicians that want to do indirect restorations. So what it means is that we apply the bonding agent to the dentine surface, which is exposed after tooth preparation. So we do a tooth preparation, the dentine surface is exposed, we use the dentine bonding agent on top of that freshly cut dentine. That procedure is called immediate dental sealing. Now, this is how it looks like. If you look at these images here, we have a tooth surface that we prepared. We have exposed the tooth surface here. The dentine is exposed. You're going to apply the bond on top of this surface and then take an impression of this. So what it means that the advantage of this technique is that you're eliminating any concern of a thick adhesive layer, okay, or the fact that you may not be able to fit the restoration once it comes back from the lab, because in this technique you have already recorded the adhesive layer into the impression, right? So because you have captured the hybrid layer into the impression, it will eliminate any concern for an ill-fitting restoration. So restoration will come back and it can be easily cemented, because this impression that we took already has taken into account the thickness of the hybrid layer here. And this technique is called IDS. Just for your information, as you start to learn more about indirect restoration. Okay, so you see, okay, so I think there was a bit of a disturbance. All right, so moving on, this gives you an understanding of your enamel surface, your dentine surface, what are the different techniques that are there in the market, total etch versus self etch, what is the advantage of self etch over total etch, what is the advantage of total etch in general, it allows high enamel bond strength, and some clinical tips in terms of immediate dentine sealing that I just shared, and then also selective etch technique that can be followed. So that is the clinical aspect. And now, what is the innovation that is there in the market that can help you achieve high clinical success rate? This is about universal bonding agents. Now, what is universal bonding agent? A universal bonding agent is something that is suitable for all materials, meaning you can use it for gold, you can use it for amalgam, you can use it for composite restoration, all different types of lithium disilicate, all different types of materials. You can use it in all different procedures. So if you're a total etch doctor, or you're a self etch doctor, or you're a selective etch doctor that wants to do a selective etch technique, you can use this bond as well. And then it can be used in all different procedures. So whether you're doing a direct procedure or you're doing an indirect procedure, you're able to use this bond. Now, what does it mean? What does a universal bond mean for the tooth surface? And what does it mean for the restorative surface? What role does the bond need to play? Now, on the tooth surface, we know tooth by nature, our teeth are hydrophilic in nature, meaning that they love water, right? So what we need on the tooth surface is that our bond is able to have enough kind of a low pH so that you are able to etch the enamel. Low pH will be acidic, will help to remove the inorganic component of enamel, give you an etch pattern, and contribute to the mechanical bond. You also want to be able to form a chemical bond. You also want the bond should have enough low viscosity so that it can penetrate into the enamel and dentine tubules, right? And because of the fact that our tooth is hydrophilic in nature, you want that the bond is also hydrophilic in nature, has a hydrophilic component, so that it can interact well with the tooth and prevent any post-op sensitivity. So that is what you need from a bond on the tooth surface. Now, when it comes to the restorative surface, what do we need on the restorative surface? We actually want that the bond is able to form a strong bond with the composite material. Okay, so that there are no gaps that are formed. There is a strong bond that is formed. Now, for us to be able to deliver that, we have to understand the nature of our enamel, the nature of our tooth, as well as nature of the composite material. Now, our teeth, all of our teeth are hydrophilic. They're water-loving substances. But the composite that we use to fill the tooth surface is hydrophobic in nature. Hydrophobic meaning water-hating. Okay. So, for example, if you take a drop of oil and put it in a glass of water, will the oil mix? No, right? That is because the oil is hydrophobic. It does not love water. It does not like water. It will not mix with water, right? So our composite material is like a hydrophobic substance that does not like water. But our tooth is hydrophilic, which is water loving. So it is the role of a bonding agent, as you can see in this picture here, to connect, to form a bond between these oppositely natured substances. And that is why the chemistry of the bond is very important. So I know usually dentists and dental students don't really enjoy chemistry so much, but it is nevertheless it's important to understand the basic chemistry that goes in the products that you're using, that help to deliver that high clinical performance. Now that is why, because of the nature of the tooth and the composite, it's important to know that your bond is able to bond to both the surfaces. Okay, so the monomer that we use is called GPDM, which is glycerophosphate dimethacrylate. Okay, this monomer has a phosphate group, as you can see highlighted in pink here. This phosphate group is what helps in forming an ionic bond on the enamel surface, because it helps to etch the tooth surface, right? And then you have two groups here, which are highlighted in blue, which are dimethacrylate, two methacrylate groups. And these two groups help in bonding to the composite material. That means that this one molecule is able to connect with the tooth, bond with the tooth, as well as bond with the composite material. Okay, so that is the monomer. The other key component in the bond is the solvent that we use. So every bond has two key components. There is a monomer and then there is a solvent that goes inside the bond. The solvent that we use, we have a patent on this technology, and in many discussions, I've seen a lot of doctors don't know about our ternary solvent system. So it is good to also let you know that we are the only company that uses ternary solvent system, because we have a patent on this. So nobody else in the market can use this system. What it means is that we use 3 different types of solvent in one bottle. So we are using water, acetone, and ethanol. And because of this combination of solvents, we are able to deliver a higher bond strength on dentine as well as enamel. How does that happen? Now let's look at these two sides of our slide. There is this description which shows you the enamel surface, and this images here, which are SEM images, shows you the dentine surface. Now, as a part of bonding, what we want is, we want a very high strength on enamel and we want a very high strength on dentine. Now, high strength on enamel will also be helped by the etch pattern, right? Because this contributes to the micromechanical locking. Now, because of the fact that we use acetone, our acetone helps in increasing the concentration of the monomer that we use on the tooth surface. And because the concentration of the monomer is high as acetone evaporates, that helps in creating a very strong etch pattern as compared to other bonding agents in the market. Okay, to explain this, let me give you an example. Okay, is there any question?
Sure.
All right, so I think...
please continue, doctor.
All right. So let me give you an example of this. Now imagine a glass of water. In a glass of water, you want to put 1 teaspoon of salt. Okay, so that is your salty water. Now, if that glass of water is full and you put 1 teaspoon of salt in it, and then the water evaporates. As the water evaporates, now in the glass, you only have half glass of water, but you have 1 teaspoon of salt still inside it. What's going to happen to this water? This water is going to taste more salty, right? Because now there is less water, but the concentration of the salt has increased. Now the same concept applies on your enamel surface. As we apply the bond on the enamel surface, our acetone evaporates. As it evaporates, it increases the concentration. It helps in increasing the concentration of the monomer on the tooth surface, and that results in a stronger etch pattern, right? That is how we are able to achieve the stronger etch pattern. Now on the dentine surface, doctors want a strong dentine bond strength, a strong hybrid layer formation also. How does this help us? How does the ternary solvent system help? The ternary solvent system has a combination of ethanol and water. Water helps in formation of acid. It helps in rewetting. Ethanol is also a rewetting agent. Rewetting agent meaning that our collagen fibers after etching will not dry out. It helps them to stay hydrated. It helps them to stay standing so that they don't collapse. And because of that, the bond that you apply on the dentine surface is able to percolate into the spaces and form deep resin tags. So these are resin tags. Now, because of these resin tags and the hybrid layer formation, we are able to deliver a high dentine bond strength as well. Right? So combination of acetone, ethanol, and water gives us best of both worlds. It helps us to achieve a strong edge pattern on enamel, and also because of the rewetting abilities, it forms a strong adhesive layer on the dentine surface as well, with deep resin tag formations, as you can see in the image here. Okay, so I hope this is clear for you. So those are the two key components of a bond, your monomer as well as the solvent. Now let's look at the full range of bonding agents that you will find in the market that we have. So just for your information, Kerr has manufactured OptiBond brand of bonding agents. And to give you a bit of a history, OptiBond is in the market. This brand name has been in the market for around 30 years now. And OptiBond FL, many of you may have heard about it. It's called the gold standard of bonding. The same technology which is used in FL has been used in all our bonding agents. The latest innovation in the market is OptiBond Universal that I explained to you, which is a single bottle system. The key advantage is of this system is the fact that it really helps you to reduce the number of steps, yet not compromise on the bond strength on enamel and dentine. Okay, so this is a bit of a history of our OptiBond family of bonding agents. Now, when you're using OptiBond Universal, which is the latest innovation, you might think, how do we actually use this bonding agent in the tooth, in the patient's mouth? So this is a technique card just to share with you the technique, various steps. So if you're a total etch doctor, what you're going to do, you're going to use an etchant on the tooth surface, right? Etch the tooth surface, rinse and dry. So this is the etch, rinse, dry procedure. Now, if you, for example, select a selective etch technique, when would you select a selective etch technique? Think about it. For example, a case which is a deep carious lesion. It is a deep class 1 or it is a deep class 2, where a lot of dentine is exposed on the floor of the cavity. However, there is also significant enamel on the KO surface margin. So you want high bond strength from the enamel, right? So you are using a selective etch technique. You will use phosphoric acid only on the KO surface margin, rinse and dry. You will not use phosphoric acid on the dentine. You will only use our bond on the dentine. Okay, so that is a selective etch technique where you selectively etch the enamel KO surface margin. The second step now, after preparing our tooth, the second step is to prepare your bond. You're going to shake the bottle. It's always important to shake the bottle because your bonding agent could be lying on the shelf for about 2 to 3 days. You don't, you may not have moved it. So before using it on the patient, it is important to shake the bottle so you mix and optimize the chemistry, and then dispense it into the mixing wells and apply it on the tooth surface. Now, this is important because I see a lot of clinicians sometimes don't follow the technique protocol. So I want to share with you the technique protocol and why do we have this technique? What is the benefit of following the technique? So we will use a micro brush to dip the bond, which is in the mixing well, and apply it on the tooth surface. Now, the motion that you have to use is a scrubbing motion. scrubbing motion to agitate the tooth surface for 20 seconds. Why is this important? Because as you're agitating the surface, you're also helping the acetone to evaporate. As the acetone evaporates, it increases the concentration of the monomer on the tooth surface and helps in increasing the etching efficacy, right? So it's important to do it in a scrubbing motion. Also, many times I've seen doctors would apply the bond on the tooth surface and we say 20 seconds, right? So doctor can go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 very quickly to 20. But that is not in reality 20 seconds. Ideal way is to really count in your mind like 1, 1, 1, 2, 1, 1, 3. That way, just go by the clock on 20 seconds, and also possible to refresh your chemistry every maybe 6 to 7 seconds. So apply the bond for 6 to 7 seconds, then dip your mixing tip again into the bond and apply it for another 6 seconds. So that is called refreshing your chemistry, so that the bond that you're applying is refreshed every 6 seconds, 6 to 7 seconds, and do that for 20 seconds. Air thin for 5 and light cure. So seasoned clinicians would really follow that technique because this allows enough contact time with the tooth surface so that the bond is able to form an edge pattern on enamel and also give you a dentine bond. Also, it helps to ensure that there is enough agitation of the tooth surface, which helps to evaporate your acetone and increases the concentration of the bond. And that again helps in stronger etching of the tooth surface. So those points are important because we need to understand why we need to scrub for 20 seconds. Air thin for light pressure for 5 seconds and then cure. So that is the technique. Now, for example, you're a doctor that is doing a indirect restoration, right? So in indirect restoration, you will apply again the bond for 20 seconds, air thin for 5, light cure. And then on the restoration side, you're going to load your cement, place it on the tooth structure, and then apply light cure agent. Now, what happens if you're using a veneer? Now, veneer preparations are usually can be in enamel. That means that there is a significant amount of enamel surface that needs to be bonded. So many times doctors will choose to use a phosphoric acid because it is on enamel and they want a high bond strength. So they can use phosphoric acid on enamel, air thin, and light cure, right? Again, when you're applying it for 20 seconds, you're using a scrubbing motion. Air thin, light cure, that is your tooth preparation. For the restoration side, you're going to again load the cement on the restoration, place it on the tooth preparation, place medium to high pressure on the tooth, and then light cure. So this is an indirect protocol. So that was about adhesion and bonding agents, which is by far the most studied, and I think for students and clinicians, it is also a very lengthy topic because there's a lot of research on it. There are a lot of terminologies, but I have just summarized this quickly for your information. And moving on to the second important step in a restorative workflow is the use of composites. Once your adhesion is completed, the second step would be to apply your composites. So this is just a slide for clinicians and for all of us to think when we are thinking about composites, what are the characteristics that we want from a composite? Now, dentistry, you know, as you are in uni and as you're seeing patients, you will see as you practice more and more patients, you tend to touch every material that comes to your clinic, right? If it is composite, if it is bonding, dentistry is a very tactile science. So the handling characteristics of materials is very important because dentists often touch their materials to see how easy it is to work with them. So composites is that product that really requires good handling characteristics by most of the doctors, because they want to touch it, they want to handling will also ensure that they are able to use the material easily in the patient's mouth. Then another factor that is not spoken about a lot is the radio opacity. Now, when you complete a restoration and send the patient back, and the patient comes back to you maybe in 1 month or 2 months or maybe 4 years, you want to be able to see whether there is any secondary caries around the tooth, around the restoration, or what is the health of the tooth around the restoration. So, a radio opaque material allows you to differentiate between caries and tooth structure. So, you're able to differentiate between the caries and the restoration. So radio opacity is very important. You're able to appreciate the margins properly. You want a material that does not shrink so much. If it shrinks, polymerization shrinkage occurs. There can be a lot of stress on the tooth that can cause micro leakage. It can cause gaps. It can also cause cracks on the outside of the tooth. The other thing is the science that we have, the science that we use behind composites, because the kind of fillers that we're using for composites actually help us to achieve all of the physical and mechanical properties. Okay. So moving on, these are the few characteristics. Moving on into radio opacity, as I shared with you, usually a material should at least demonstrate about 100% aluminum radio opacity so that you're able to appreciate it. All our composites, our materials are in the range of around 250 radio opacity, and that is really important and helpful for clinicians because they're able to diagnose any secondary caries of around the restoration, which is an important factor. Okay, so giving you a bit of a history on composites. Now, when we started manufacturing, when the dental market starting manufacturing composite materials, they talk a lot about macrofill materials. Macrofiller materials were the older generation materials that used bigger size of filler particles. And then we came up with microfill composite materials. Now, what macrofill? Macro stands for big. So macrofill, the earlier generation of composite materials had bigger filler particle size, which means that they had a higher fracture toughness. They had higher mechanical strength, but it was very difficult to work with those materials because they are very stiff. So very difficult to work on anterior restorations. You need to pack the material. They're stiff. And then they're also not very easy to polish because the filler size is very big. So in order to overcome this, companies came up with microfill materials. Now microfill use smaller filler particles, but the smaller filler particles, what it does is that these filler particles help you to polish the restoration better, but the strength of the material is also lower as compared to the macrofill materials here. So meaning to say that there was a challenge of strength versus polishability. The latest generation of materials that we have in the market is the nanofill materials, which are very small nanoparticles. As you can see, a nanoparticle is so much smaller than 1 micron. So it is really, really small sized particles that are used as fillers in the composite material. And what is the advantage? Now imagine these two patients. Imagine this is one patient in which a macrofill composite material was used, and this is a composite patient in which a composite is used that has very small filler particles. Now what happens when both patients go back home after getting their dental treatments? They're going to brush their teeth over and over and over again. As they brush their teeth, the resin on the tooth surface is going to get worn off, and the filler particles are going to get exposed. As the filler particles get exposed, they get plucked out into the oral cavity. This phenomena is called the plucking out effect of composites. Now, as these get plucked out, what is the clinical symptom of or clinical sign of this phenomena. What happens is that the patient is going to experience patchiness, loss of gloss, yellowness, staining in their restoration, okay, because of wear. Now what happens if the restoration is filled with composite material that uses very small filler particles? Again, the same thing is occurring. The resin is going to get worn off. There will be filler particles that get exposed to the oral cavity and get plucked out over a period of time. As they get plucked out, the difference here is that the craters that they leave behind are much smaller as compared to the craters that you see here. So at a macroscopic level, the surface still looks smooth. So that means that the patient is able to have a gloss for a longer period of time. So their restoration is going to stain less, is going to maintain its gloss. The life of the restoration is going to be much longer as compared to a material like this. So that is the key difference. Okay, so moving on to with that history of microfill, macrofill, nano composites, the latest generation or the latest innovation that we have in the market from Kerr is called Harmonize. So Harmonize is our latest universal composite material. Now, what does universal mean? We talked about universal in bonding agents and then universal in composite materials. Now, what universal composite material means is that it can be used in anteriors as well as posteriors. So you don't need to have a separate bonding agent or a separate composite material for your anteriors and a separate for the posteriors. The same material can be used in anteriors and posteriors. Now, important part about this composite material, this is a universal composite material. It is really easy to use. You can use it for anteriors and posteriors, very superior chameleon effect. Now, all of these properties that we will talk about later comes from the science that we use to manufacture these products. So not getting into too much details, but giving you an overview of the fillers that we use. We use silica and zirconia. So silica and zirconia are oppositely charged and they are fused together because of the opposite charge, and there's an ionic bond and attraction. And these spherical balls are then infused into the resin matrix. So the primary shape of the filler particles is spherical that we use in our composite material, and we use silica as well as zirconia particles. The combination of these particles helps us to match the refractive index of natural enamel. Okay, so that is the science. Now for aesthetics, we know three main factors the three key factors for composites is one, the handling. We need ideal handling. Second is the aesthetics. We also want to be able to achieve beautiful restorations that are lifelike, which are natural looking restorations. Now, for that, we need to understand the behavior of enamel in different wavelengths of light. Now, if you look at how enamel behaves in lower wavelengths of light, if you can look at this image here. Now, as enamel or a patient walks into an area where you have a lower wavelength of light, for example, blue, the human enamel has a tendency to reflect more diffused light. That means, what does that mean? That means that the enamel is going to look matty, it's going to look dull, right? So as compared to when a patient walks into an area that has higher wavelengths of light, maybe red wavelength, in that kind of an environment, our human enamel has the tendency to give out more specular light. Specular light means that your tooth is going to shine out. It is similar to how you look into the mirror and light reflects straight back at you. That is specular light, right? So in this case, the enamel is going to look shiny. So So what it means is that the human enamel behaves differently in lower wavelengths and higher wavelengths of light. And that is why the technology that we use, which is silica and zirconia infused spherical filler particles, they help us to achieve this behavior, similar behavior as natural enamel, to be able to offer superior chameleon effect as compared to the others in the market. So the restoration that you make with Harmonize is going to seamlessly blend with the adjacent teeth, because it mimics the behavior of natural enamel in lower as well as higher wavelengths of light. Okay, so this is the number of shades that we have. In a couple of minutes, I'm going to talk about some clinical tips and tricks of shade selection and how to do a direct veneer. So for that, it is important to also understand the range of shades that we have. So we have dentine, enamel, and incisal range. Most of the restorations could actually be done with dentine, with enamel. Also, for your information, dentine is usually the range of shade that has the highest opacity, followed by enamel, and then incisal is the lowest in opacity. Okay, so look at these clinical images here. We are able to fill this restoration mesial fracture with B1 enamel. Now, Caucasian patients use B1 enamel because they need bright white teeth. In our region in Asia, we generally use maybe an A3 or an A3.5 kind of a shade. Again, you can see here multiple cases, multiple images of the case where we've been able to do the restoration just using one shade, B1 enamel. Here, there is again a midline diastema that has been closed with A2 dentine and A1 enamel. So we used two shades, used a darker dentine and followed it up with A1 enamel to complete the restoration. So those were some of the clinical images that we have that depict the use of harmonized. Okay, so if we look at the composites that we have, the latest that we have in the market is the universal composite here, Harmonize, that will help to do aesthetic restorations, anteriors and posteriors, using the conventional layering technique, right? But if you wanted to do restorations fast and you had a lot of posterior restorations, you wanted to speed up your procedures, then there is another type of restorative material that we have, which is called Sonic Fill 2. There is no one in the market that uses this technology. I will share with you in a few slides how this works. But before that, let's understand the science of color and how we should be selecting shades, and then look at the very simplified way of doing a direct aesthetic veneer, right? So this is actually a Munsell color system graph. This color system defines the three basic attributes of color. So when we say color, color actually has three attributes. There is a hue, there is chroma, and then there is value, right? So if you look at this graph here, this vertical pillar here is stands for the value. So value is black, meaning that it is 0. Highest value will be white because it is fully bright, right? Then color has a hue and a chroma. So hue is the basic type of color. So for example, here in the graph, all these vertical palettes that you see, horizontal palettes that you see, represent different hues of color. Okay, so there is a orange one, there is red, there is purple, there is green. These are different hues. Now, what is chroma of color? Chroma means how much color or how much color there is in of that hue. So if you have to understand it using the graph, you can look at these horizontal palettes. So I have just put one palette on the side. Now, if we have to explain the 3 attributes of color using this palette, the hue of this palette is yellow, right? Because that is the basic color. The chroma here is low. On the right hand side, the chroma is high. Why? Because it is more filled with that color. Now, if we look at this palette here on the left hand side, this is 0 in value because it is absolutely dark. And this part, this corner here is high in value because it is white. So value is basically the brightness of color, and hue is the basic nature of color, different hues that you see here. And then chroma is how much color there is in the substance, right? So this is low chroma, this is dark chroma, high chroma because it is more filled with color. And that is how we define color. Now, what happens in our mouth, in natural teeth? How do we define colors? Now, let's look at these images here. Right? If we observe these images, we can see there is enamel actually looks like there are 3 different types or different colors of enamel. Now, when it comes to natural teeth, the hue in your natural teeth, which is the primary color, the primary source of the color is our dentine. Enamel doesn't give us any color, right? So the primary source of hue in human dentition is actually dentine. Now, chroma, when it comes to natural enamel, is dictated primarily by the fact by dentine, right? The thickness of dentines, the thickness of the enamel on top of it. Value is influenced, value, which is the brightness, is influenced by the thickness of enamel. So enamel, what enamel does is that it regulates the value, and it provides that optical effects that you see in teeth. I'll show you a few optical effects in the coming slides. But just to understand, when it comes to natural teeth, the hue comes from the dentine. Chroma in natural teeth is primarily dictated by the dentine, which is influenced by the translucency and thickness of the enamel. So how translucent is your enamel, how thick is your enamel, that is going to be a determining factor in the chroma that you're able to see in your tooth. And I'll show you what that means. And then value is how bright your tooth looks. This is basically regulated by the thickness of enamel. Okay. Now, enamel also causes a few of these effects on the incisal edges. This effect is called the opalescence. Now, this opalescence, you can see blue comb-like structures on the edges, incisal edges of the tooth. Now, these are formed, these are because of the opalescence that is created by enamel. Enamel is highly inorganic. There are hydroxyapatite crystals, and they have different refractive indices. So that means that longer wavelengths of light pass through enamel and shorter wavelengths of light are reflected. And because of that, this honeycomb-like blue structures are seen, and this is usually in younger dentition that you would see. Opalescence is a property of human enamel because of the fact of that we have a high inorganic rate and we have hydroxyapatite crystals of different refractive indexes which reflect light differently, and they cause this effect. Now, this is important because if as an aesthetic dentist, you may want to create those effects in your teeth. Now, we talked about the chroma of the tooth also. Now, if you look at how the cross section of a tooth, human tooth looks like, at the cervical third, you will see that the thickness of enamel is very, very low. It's less, which is why you will see the dentine shade of your tooth will be most visible here. So the chroma is going to be higher in the cervical part. In the middle third, the enamel thickness is greater. So it's going to be brighter here because the value is going to be higher. And in the incisal third, where the enamel thickness is greater, again, this gives you the different characteristics of opalescence and those blue-gray like structures that you see, effects that you see in the incisal edge because of the fact that enamel reflects light in different manners, because of the refractive index of our inorganic components. So this cross section in itself tells you the varying thickness of enamel from cervical to the incisal edge and how that regulates the chroma of your tooth. Now, clinically, enamel is actually of three different types. There is young enamel. You will see a young patient, their enamel looks different. Then you have an adult patient. The third type would be an old patient. Now, young patients would have higher value because the enamel is thicker, it's less translucent. As patients get older, their enamel thickness is worn off. There may be intermediate level of translucency. And as you grow older, what is happening on the dentine side also is your dentine is becoming more sclerotic. In addition, your enamel is getting worn off. There is staining that is occurring. So overall, the effect on the tooth can be, it can look much darker. And definitely there would be wear on the incisal edges and very less opalescent effect because of the functional wear that incisal edges would have been worn off. So that is the understanding of enamel and how it regulates the chroma of your tooth structure. Now, when it comes to actually mimicking the shades or the aesthetics when it comes to composite restorations, shade taking is an important step. What you need to do is to evaluate, the first step is to evaluate the shade of the adjacent teeth and the tooth that needs to be restored, right? So what you need to do is to assess the dentine at the cervical tooth third, because when you assess the dentine at the cervical tooth third, that is going to give you your dentine shade, right? Because enamel is very thin here, and you can the dentine effect can be seen very obvious in the cervical third. So your dentine shade should be matched against the cervical. Another, before we move forward, a clinical tip here is to remember that when you do your observation and shade taking, it is important to do it prior to isolation. Because if you isolate the tooth, the patient has been sitting in the chair for maybe 10, 15, 20, 30 minutes. Because of isolation, the tooth is going to get dehydrated. As it gets dehydrated, it's going to look higher in value, but that's not the actual tooth color. That means that if you match your enamel against this tooth, you're probably selecting a higher value. And when the patient goes back, the tooth takes usually 24 to 48 hours to rehydrate. When the surrounding teeth rehydrate, the tooth that you have restored is not going to match with the adjacent teeth. So that can cause aesthetic failure. So it's important to do the shade taking prior to isolation, so you can get the actual shade of the dentine and the enamel that you want to use. Another clinical tip that many clinicians use for selecting the composite shade is to create their own shade tabs, which is the most predictable and effective way, because you're using cured composite material, the shade of the cured composite material to match it against the tooth, right? Instead of using maybe acrylic shades, which are not an exact match. So this is an important clinical tip for your reference. Before we get into the technique of doing a clinical aesthetic veneer, I want to just share with you the types of veneer preparations that we have, generally the types of veneer preparations, and when do we know which one is indicated. So if you look at this ABC here in the picture, based on the level of spread of caries, we may want a facial view of the partial veneer. So that means we create a partial veneer, right? Only to the extent of the caries. The second example would be to create a preparation of a full veneer with a window preparation design. Okay, so we are doing a full veneer and the preparation design is the window preparation. We have not involved the incisal edges. The third design is to do a full veneer again where we have involved the incisal edges. Now, many times doctors would or would ask on this question that how do we decide which preparation to do, whether to involve the incisal edge or not involve the incisal edge. So a general guidance for that question is that if the caries is involving the incisal edge, the lingual side, the incisal edge of your tooth, then you will need to extend your preparation also to get rid of the caries, right? So you would need to extend into the incisal edge and maybe give it a butt joint or maybe do an incisal lapping design here, F1, F and G. So the general principle is that if you see there is caries involvement, you would extend based on caries involvement, and based on the material used, you would give a butt joint or you would give an incisal lapping design. Sometimes the crown lengthening is required. In those cases also you would want to involve the incisal edge. So based on the clinical symptom as well as the indication, you would decide which veneer preparation we want to go ahead with. Okay, now coming to this very simple technique to do a direct veneer. So seasoned clinicians would actually use maybe 4, 5, sometimes 6 different types of shades, composite shades, to do a direct veneer. In this technique, we are actually only using 2 composite shades, 2 composite masses to complete the direct veneer. Now, this technique is note that it is indicated in cases where your tooth does not have any inherent discoloration and only a change in the morphology is needed, right? So the first step is going to be ensure that you evaluate the tooth structure and the adjacent teeth, evaluate the level of chroma that you have and the level of translucency that you have at the incisal edges. Your dentine should be assessed against the 2 to 3 area in the cervical region. Sometimes doctors would match the dentine against this area and match enamel against the middle area where the value is the highest, right? So we will do that in evaluation. Following that, we will start the procedure. Now, the first step of this procedure is to apply a tint. So we are trying to mimic the dentine shade, the chroma from the dentine. So we're going to use, in this technique, we've used a very fine layer of a tint, which is from Kerr. We have a resin tint that can be used to create these natural effects. So we're using a brown tint, very, very fine layer here using a paint brush, 0.1 paint brush. Paint it on the cervical third of your tooth and then light cure it. That is step number 1. Step 2 is to place your first composite mask. So here we are taking, based on the shade, maybe you want to use an enamel A3 or A35, depending on the dentition of the patient. So we've used a big mass of composite here, and then you can use your favorite composite instrument to model this material. So clinical tip here to remember is that many times I've seen students taking small bits and pieces of composite and adding it to the tooth surface. Now, what that does is that it increases the risk of including air bubbles into your restoration when you polish and cure. So in order to avoid that, it is best to use a bigger mass of composite material that you can work with using your composite instrument, and that reduces or eliminates the risk of incorporating voids in your veneer. Okay, so we're going to work with it. Here we've used some instruments, spatula, to model the mass. As you can see, the composite mass is a little in excess, so it is going past the incisal edge. We will flatten it out again. Again, it's a bit excess and going past the incisal edge. Now, in order to finish the facial surface, we would have to cut this excess composite material. So cut it at the level of the adjacent tooth. So many doctors would stop here. They would cure and polish at this step. Now, you could do that too. However, what this tooth is going to lack is the translucency that you need in the incisal edge. Now, in order to create that translucency, we will use another shade, another mask of shade, but we need to create a space for that. So in order to create space, we will use, here I've used an IPCL instrument to cut the excess enamel shade. Now, as you see, please note the angle at which the IPCL has been kept. We don't need to create a butt joint here. We want to create a slant when we are removing the excess, right? So this slant will help us to ensure that we are able to blend the second shade into the enamel shade. Okay, so note that you cut the material in a slant. Now that is the facial aspect. You also need to cut the excess from the mesial and the distal. So here we are cutting mesial, distal. Now before we move on, sometimes question can be, how do we know what is the extent of the cutback? How do we know whether we need to go all the way to the contact point or into the embrasure? Now that reduction will come from your initial evaluation of the translucency of the tooth, right? So if there is greater translucency in the incisal edges up until the contact point, you will cut deep into the contact point to remove the excess and add the second shade, which is the enamel shade. So initial evaluation of your tooth structure is key. Following the cutback, we will use a conical instrument like this one to create grooves on the enamel surface. This will help to blend with the subsequent layer. After that, we're going to cure this final layer. So these are two steps. Step number one was using tint 1 followed by composite shade number 1. The third step is to apply tint number 2. So this tint is blue in color. We have to use really, really little quantity of the tint using a paintbrush into the embrasures. So you can see how we are applying this here. Okay. Once we've done that, another point before we move forward is the fact that you have to ensure that you don't apply too much of the material. It should be very, very little. You shouldn't be able to see it. You should only see like a very faint gloss. Okay, so that is what we do. Final step is to apply the second composite mask, which is your incisal shade. So you're going to apply the incisal shade and use this spatula or hand instrument to model the incisal shade. So one important clinical tip here is to tack the material down and then work with the rest of the material. What happens is that if you're trying to work with the entire mask, it is also moving at the same time, so it becomes difficult to control. So important tip here is to tack the mask down at one end and then work with the rest of the material. And here, as we can see, we will use the spatula to model the second composite mask and ultimately achieve the morphology of the adjacent tooth, as you can see here, and cure. Now, After curing, the next step is to polish your restoration. So as we saw in this technique, we only used two different composite masses and added two tints to complete the restoration. Now, final step is polishing. Usually doctors would use 5 to maybe 7 minutes to polish. Now, before we get into the polishing, I just want to share with you some conservative aesthetic procedures that you could do to narrow your tooth or widen the tooth. Now, if you look at normal tooth structure, if it looks too wide, right? If you have a lady patient, a feminine looking face, and the restoration looks too wide, you could actually just place the embrasures, middle embrasures closer to each other, which helps in narrowing of the tooth. And if you place these further away, that helps in widening of the tooth. And this is an illusion that you create because it increases and decreases. We are basically playing with the reflective surface of the tooth structure. Again, similar kind of tricks can be tried on shortening and lengthening your tooth. So for example, in order to shorten, we could play around with the horizontal elements of at your gingival level. And if you place them further incisally, meaning that you place them towards the incisal edge, that reduces the reflective surface here and helps to make the tooth look short. And then if you wanted to lengthen, these horizontal elements should be placed further up towards the gingival third, or just not emphasize on these, to increase the surface area here, which is a reflective surface area. And that gives an illusion of lengthening of the tooth structure. Okay, so just an example of such conservative aesthetic techniques. You can see two smiles here, two women smiling. Now, just if I had to ask, or you had to think in your mind, which woman looks younger in these two cases? If your answer is right hand side, you are right. But the fact is that they're the same patient, because it's the same smile, it's the same patient. All we've done is that we have reduced the prominence of the facial line angles, and we've also rounded the incisal angles here and created embrasures. And that has helped us to give a more younger looking smile to the patient. So just a cosmetic tip to try and look out for as you're doing your aesthetic procedures that can help to give patients a younger looking smile or just improve their smile. Okay, so that was about some conservative techniques. Moving to the final stage in direct veneer is your polishing, right? So if you wanted to do polishing, you need to ensure that you observe your tooth structure from two aspects: the incisal edge, the incisal aspect, right? Because you want to see the thickness of your incisal angle. I've created lines here. If you look at the next image here, what you need to observe is the transitional line angles. Again, I've marked the transitional line angles similar to how we see in the adjacent teeth. Okay, so the next step is to actually create those embrasures and transitional line angles. Note the angle at which we place the disc. The third aspect is to observe the facial surface. Now, what we're doing when we look at the facial surface is that we have to ensure that there isn't much, the contour from the facial is flush with the adjacent tooth. So if you see that you have added a little too much of bulk on the middle third, you can use light brushing motions to reduce that bulk. But you need to observe the tooth from the lateral side as well to be able to understand how much reduction is required. And then the final is to round off the line angles and point angles. So always remember, you need to observe from three different aspects: your incisal, transitional line angles, facial, and finally the line angles, the line and the point angles, which is to be rounded off. So that is the primary anatomy that you can build with polishing. Now, most of the time we do primary anatomy. I just added this information here for you all for secondary and tertiary anatomy as well. This secondary and tertiary anatomy is not very prominent in Asian patients. We don't see very prominent secondary, tertiary anatomy. But just if we had to create, and for your information, we could use conical diamond red band burr to create the middle embrasures, and then horizontal embrasures using semicircular motion all over the facial aspect to finally give the secondary and the tertiary anatomy. So just note the different strokes that we need to do to create the secondary as well as the tertiary anatomy, and this kind of a burr helps in creating those surfaces. All right, so moving on to another clinical tip here. Many times we would observe that we have some ditches or we have some voids on the composite restoration, and we don't want to remove the entire restoration. So oftentimes what we could do is to use a round burr to actually engage into the irregularity, remove and create maybe a saucer shaped preparation. If you find that the cavity is deeper into this preparation, then you could use a smaller round burr to get into that preparation, as you can see in the image here. You can etch to remove the debris and then bond. You don't need to light cure, and then add your composite material and finally light cure the material. The final step would be to smoothen out that part, that void that you have, using a suitable polishing instrument that helps you smooth out the surface. Okay, so that was about direct veneers. And direct veneers, as we know, we do layering technique, right? So another innovation that is there in the market, which is very interesting to know, is the bulk fill technique. Now, what is bulk fill technique? We in dental school study to use a layering technique to place our composite materials in a restoration. Layering technique, conventional layering technique, would mean that you don't place material in greater thickness than maybe 2 mm. That is the maximum thickness you want to take, because you don't want to apply a lot of polymerization, shrinkage, stress on the tooth. You want to avoid that. And that is why we use the conventional layering technique. However, conventional layering technique can also be time consuming, right? So in order to simplify procedures for doctors and also to enable you to do more number of restorations, there is a technique called the bulk fill technique that is now becoming popular. What it means is that you're able to fill the entire restoration in one step, right? So that is the basic concept. Now, when it comes to this concept, there are concerns that doctors can have. So what are the differences? Just think about it. If you were told that you have a conventional layering technique and now you can place the composite material in one shot up to maybe 5 mm, what are the concerns that would come to your mind? So we've just listed out some of the concerns here. Firstly, doctors can worry that how do we know that we have adapted well to all the parts of the cavity, right? How do we know that we have reached all the nooks and crannies because we are placing one big chunk? Okay, so that is one concern. Second concern can be on the curing. So how do we know that when we cure this material that we are curing from the top, that we are able to also cure the material at the bottom, because this is 5 mm. So it's a deep cavity. We always place in layers. Now, how do we know that we are able to fulfill the entire depth? We are able to fully cure the entire depth, right? So that is one other concern that I hear. The third concern, which is shrinkage stress. We use a layering technique in order to reduce the polymerization shrinkage, to lower the shrinkage stress. Now, because we are placing the restoration in one shot, that means that there can be a lot of shrinkage stress that is created, and that can cause pressure on the tooth and cause failure. Okay, and the final could be the functional characteristics. Does it give enough aesthetics? Is it going to be strong because we are placing 5 mm in one shot? So these are basically the kind of concerns that clinicians have, and requirements that they think a bulk fill material should be able to offer in order to successfully be used in a clinical practice. Now, Sonic Fill 2 system, which we have, which is a composite system, is able to provide all of those uh, features that the doctors are looking for, as we see in this slide. Now, what is this system? We have composite material like this, and then we have a handpiece. The material can be activated using a handpiece, right? Now, let's just see how it works. This is an oral cavity. This is the unidose and the handpiece that I just showed you. Okay, so what we are seeing here is that the material is coming out of the tip. This is the composite material. We filled one cavity, we've gone to another cavity, and then we've filled the third cavity as well. So typically, this is how a sonic fill bulk fill system will work in the patient's mouth. Okay, so let's take a closer look. Now, this is a pedestal tooth, artificial tooth, and this is the tip of the unidose, and we are going to activate it. Now, as we have activated the tip, we can see how the material is dispensed out of the tip, and you're able to fill the restoration from one side, one end to the other end. Please note that your composite material was constantly dipped. Okay, let's just see it again. You will see that the material is constantly, the tip is constantly dipped in the material. This helps to constantly vibrate the material. The next step is going to be doctor is going to use a tip to pack this material into the restoration, carve it, and then cure. Okay, so what is happening here? What is happening is that we have a handpiece. The handpiece goes into the high speed of your chair, and you activate the handpiece. As you activate the handpiece, there is sonic energy that is generated in the handpiece. It is an air-driven handpiece. And this sonic energy is then transferred onto the composite. Now, as the composite experiences the sonic energy, the viscosity of the material drops. Now, viscosity of the material drops, and that is the placement stage. Now, what is happening in the placement stage? The material comes out as a flowable. So, as you can see in the videos, the material comes out as a flowable. Now, when it comes out as a flowable, you fill the restoration and stop your cavity preparation. You stop your handpiece. There will be no more sonic energy that is applied, and the material is going to not suddenly become hard. So the material is going to take some time to regain its viscosity. And why is it important? Because this is the time that you're going to use to shape and sculpt your material, right? So this gives you the place. This is the whole idea of how it works. Before activation, the material is high viscosity. As you activate, the material drops in viscosity, becomes like a flowable. This is when you're able to adapt it well to all the parts of the cavity and fill the restoration. And as you stop activation, the material is going to take a few minutes to get back to regain its viscosity, which is the time the clinician has to easily carve the restoration. So let's just see some of the technique errors that doctors that users can make. Okay, so the error here is that you did the procedure too fast, and because of that you incorporate voids. You need to ensure, in order to avoid this, you need to ensure that you place the tip of the handpiece or the unidose tip at the bottom of the cavity here and slowly go up and towards the other end, and do not go back and forth because that can increase the chances of incorporating voids. Okay, so this is how the voids would look and cause failure of the restoration. So some summary points here also that I've noticed clinicians or users can sometimes miss. It is important to ensure that you press on the foot pedal, your rheostat, all the way through. So you have to activate the handpiece as you start the procedure and keep it activated till the end of the procedure. So that is important because that will help you to reduce any void incorporation. Okay, and then another tip is to make sure that the tip of your unidose is constantly dipped in the material. That is also an important thing because that ensures that your material is constantly activated. Right. So this adaptation that we saw, the activation of the material and reduction in viscosity helps you to adapt the material very well in all nooks and crannies of your restoration, because your material, your composite material, behaves like a flowable. So it will flow in all those areas, and that helps to address the concern around adaptation. Right. The second concern we had is about the curing depth. Now, as per the industry standards, when you measure, when you cure a material and you measure the thickness at the bottom and measure the thickness at the top and take a ratio of this thickness, if it is 80% of or more, it is considered to be clinically acceptable. With sonic fill, we are able to achieve 97% of this ratio, which means that we don't have to worry about the thickness of the 5 mm, and we are able to achieve ideal curing at the bottom of the cavity also. And that's because of the kind of fillers and the composition of our composite material. Now, some of the clinical cases you can see it is a class 2 cavity and we filled it in one shot with composite, with sonic fill. Now, this is just a video for you to appreciate how a layering technique is conducted and how bulk fill restoration is conducted. Okay, so that is how you can speed up the procedure with bulk fill techniques. The next final part of our presentation and discussion today is polishing of restorations, which is whether you're doing a bulk fill restoration or you're doing an anterior restoration, you would need to polish it. So, what polish really does is that it helps to, as a part of the technique, you will be using ever decreasing grit that to scratch the surface of the restoration, and eventually the final grit size is so fine that you're able to scratch, and it leaves very smaller than wavelength of light scratches on the surface. So that helps to smoothen out the surface and add that additional shine. Now we have polishing. Kerr has industry leading polishing tools, which are called opti discs. They're very popular in the US, in EU, in Thailand, and other countries, and Indonesia. They're also available. So this is a color coded system. Now, as I said, what polishing really means is that you're using an ever decreasing grit size to scratch the tooth surface. So ever decreasing grit size, we have the same in our polishing system. So you start with an extra coarse and you go to extra fine. So from clinician experience also, I can tell you that in order to achieve highest gloss, you must follow through the entire levels of the shades that we have here, meaning to say that you start with the darkest color, go to orange, go to yellow, and then go to lighter yellow. And if you touch these, the abrasive surface, you will also realize that the one which is extra coarse has the maximum coarseness. So sometimes what doctors do, maybe start with extra coarse and then jump to just high gloss, or do finish or coarse and medium and then just do high gloss, right? So if you ideally want the highest gloss, you must go through all four steps. The other tool that we have is called Oclu brush. It is actually the paste, the polishing paste is already impregnated into the bristles, and so you don't necessarily need to use water or any additional paste. And this can be used for anteriors and posteriors also to give you extra polish of the restoration. And you can see that there is a concave side that gives you a better contact with the surface. You can use it for composites, compomers, also for glass ionomers. And so that brings me to the last slide of the presentation. Um, the floor is now open to questions if there are any. But what I would like to summarize here is also for any procedure, we usually, when it comes to polishing, I've seen doctors would probably just spend maybe 3 to 4 minutes doing polishing. Irrespective of the time that you spend, you have to ensure that you do not you use light brushing motions. Do not put a lot of pressure using your hand instrument, because that can increase the temperature of your tooth also and generate a lot of heat, which you don't want. So it's always ideal to use light brushing motion to complete your polishing steps and use the right tools. So for example, OptiDisc, OpClue brush, they help you to really reduce and also polish at the same time. Okay, so that's the final slide. We have a few minutes left. So if there are any questions or any clarifications, you can put them in the chat box or just ask them.
Dr. Asis,
Yes.
here we have a question from Kim Henadi, the student. Good morning. Thank you, Dr. Asis Sodi, for your interesting presentation. My name is Kim. There's a question. First one, how do you differentiate in clinic easily adolescent, adult, and sclerotic dentin? Oh, I mean, how can you diagnosis it's adolescents or adult or sclerotic dentin for ETSA and bonding technique?
Yeah, so that is actually a clinical guess based on the age of the patient. You know, sclerotic dentine is also while you're doing preparation. So, adolescent dentine, based on the age of the patient would be an adolescent. So, we could use a general rule that based on the age of the patient, adolescents should be maybe 5 to 10 seconds of etching. But when it comes to actually preparing, what I can tell you is that when you go from enamel to dentine, you immediately feel a dip, right? So a sclerotic dentine is going to be harder than adolescent and darker than adolescent dentine. So that is a visual indication that tells you that this is sclerotic dentine. There is sclerosis happening as the dentine is darker and it is harder to prepare. So you use your burr to do the preparation in enamel and dentine. So as you're preparing your tooth cavity, you will actually have a tactile sensation when you go from enamel surface into dentine while you're doing the preparation. So when you're doing the preparation from enamel to dentine, the doctor is able to appreciate that there is a sudden dip or a smoothness that you can
Jadi mantan ya penting tuh udah lama banget ya. Udah lama 2 tahun yang lalu.
right.
Tapi kan masih kayak aku suka tanggepin di DM gitu. I see tadi aku.
Yeah, can you mute? Thank you.
Yes.
So that is the difference between enamel and dentine. And when it comes to dentine, different types of dentine, then first is most important is to look at the age of the patient. And then when you're actually doing the preparation, a sclerotic dentine is going to be harder to prepare as compared to an adolescent dentine. And so that should be your guideline to go with 5, 10, or maybe 15 seconds.
Okay, thank you, doctor. And the other question, what is your opinion about using selective etch technique if the student only have the 5th generation bonding battle of bonding?
Yeah. So if you only have 5th generation bonding agent to bond, you wouldn't need a selective etch technique because as per the 5th generation bonding agent, you need to use phosphoric acid all over, right? So selective, yeah. So in that case, for a 5th generation, you would use the etchant all over the tooth, and then use your one bottle, which is the primer and the adhesive together to bond the tooth surface. So as a technique for 5th generation, you need to use phosphoric acid all over the tooth surface. Selective etching is used in combination with self-etch bonding agents because self-etch bonding agent will already have the acidic primer inside the bottle. So you don't need to etch separately the dentine surface. The key difference between the 5th and the 6th generation bonding agent is the fact that 5th generation does not need to have acid in their chemistry because you're using a separate phosphoric acid step.
Okay, thank you for the question. And there's a lot of questions. Be patient, doctor, please. We have the third one. Okay, this is still from Kim. We know that we can offer etch a dentine, but otherwise, I'm just curious, can we offer bond a dentine by mean? Is there a negative impact toward our final restoration? You have explained the technique using OptiBond that we better renewing the chemistry material at least 6 until 7 seconds per time by dipping the microbus to the bonding solution. How many times should we dip it during our 20-second scrubbing?
Yeah, so our, in a 20-second scrubbing, you would probably dip your brush about 3 times.
3 times, okay.
Yeah.
So is there any what is it? A negative impact toward final restoration if we overbond a dentin?
Yeah, how will you overbond a dentine? You cannot overbond a dentine. You can only do a wrong technique. So if you are using too much bonding agent, or you're not evenly, or the viscosity of the material is not right, it is too thick. Overbonding is no term as such, but what I'm thinking, what you're saying is that what if your bonding to dentine is not done correctly? Yes, that will impact the fit in a negative, in a indirect restoration. If you're thick, the bonding or the adhesive is too thick, that can cause an ill-fitting restoration. In a direct restoration, if you're using too much of a bonding agent, then there can be pooling of the bonding agent that can occur on the tooth surface. So you don't want that, because you want to follow the right technique. So in short, in summary, if I had to tell you, you can ensure that you're firstly refreshing your chemistry, and then lightly air drying the tooth surface also, to ensure that the material spreads well all over the surface, and there is a fine layer that is formed, and there is no pooling that occurs that can impact the bonding.
Okay, thank you. So it's better to do the good one. Okay, for now from Suka, another student. She asking the first one, what is the function of refreshing the bonding several times? What means?
So I want to explain this maybe using another analogy. So what happens if you're using a hand lotion, for example? You take hand lotion and apply it on your hand, right? And it is not enough to cover your full hand. So you will need a little more hand lotion to cover your full hand. It is the same kind of ideology. What you're doing is that you're ensuring that you have enough bond, that you're refreshing your chemistry to apply to the tooth surface. So if you dip your microbrush once in the mixing well and apply it on the tooth surface, and you're rubbing it over and over again, there is acetone that is getting evaporated. Then you want to dip it again so that you can get more bond. You can refresh your chemistry and go back to the surface to apply the same bond, so that there is sufficient bond and there is sufficient contact time for the bond to act on the surface.
Thank you. And the second one, what is the rationale behind the low shrinkage polymerization? Also, we put the filling in bulk.
Yeah. So you would have read about, or in the following years you will read about shrinkage, polymerization shrinkage. So what polymerization shrinkage means is that composites inherently, because of the way they are manufactured, they will shrink when they are cured, right? And as composite materials shrink, they can exert a certain amount of stress on the tooth structure. So that is why we have come up with this technique of conventional layering technique, where we put small amounts of composite material so that there is not a lot of stress that is generated when they are cured. So composites inherently will shrink on curing, and there will be a shrinkage stress that will be created. Now, if we put a lot of material in bulk, then that means a lot of material is curing at the same time, and there can be a greater shrinkage stress that the tooth is exposed to, because of the higher shrinkage that is happening at that point. So why do we need a low shrinkage in bulk? Is because we are placing a lot of material at one time, and we are going to cure all of that material at one time. We are not placing layers. So we want a low shrinkage material, so that when we cure this 5 mm thick layer, there is very little shrinkage stress that is applied on the tooth, and it doesn't cause any kind of post-op sensitivity.
Okay, thank you.
So,
And
just one more point. So the universal composite materials cannot be used in bulk because they are not manufactured to have low shrinkage. they should be placed in conventional layers.
Okay, thank you. And for the continuing the previous question, do we still need to do a special technique of light cure, like tech curing or soft start curing, in effort to help reduce any polymerization shrinkage that could lead to micro leakage, or does backfill eliminate risk of micro leakage somehow?
Yeah, so the micro leakage you're talking about is primarily from the concern of polymerization shrinkage. So the material that we are talking about here, sonic fill, it has been manufactured in a way that the shrinkage stress that it creates is very, very low. We have highly filled this material. It is over 80 to 85% filled, which reduces the amount of resin that is present. And resin is actually what shrinks. So, in summary to your answer, the technique that we follow is that we want to place sonic fill in 5 mm thickness, not greater than that. So, if you have a cavity that is 7 mm in thickness, you will probably do 5 layer, cure it, do a 2-layer separate, and then cure it, right? So the first important thing to remember is the thickness that you can cure at one time, that is 5 mm. The second thing is the technique for curing. The technique for curing for sonic fill restorations is to use curing lights. We cure from 3 surfaces, whether it is a class 1 or a class 2 restoration. It should be cured from 3 surfaces. So you will apply 20 seconds of light on the occlusal surface. For example, it is a class 1 cavity. So the curing technique is going to be 20 seconds light curing occlusal, then 20 seconds buccal, 20 seconds lingual, right? After that, if there is a class 2 cavity, for example, you're going to do 20 seconds occlusal, remove the matrix, and then do 10 seconds buccal, 10 seconds lingual. So 20, 10, 10 is what you have to follow for curing technique. You don't need to do a separate kind of a intermittent curing or tack curing for that matter. Tack curing is for indirect restorations primarily. So the material has been manufactured to be able to be cured in a thickness of 5 mm, not greater. So in summary, need to remember 2 key points about curing. One is the thickness of the layer, so 5 mm, and second is the number of seconds that you will apply. You will apply 20 seconds occlusal, 10 seconds buccal, 10 seconds lingual.
Okay. Thank you for the answer, and this is really interesting. Mungkin mahasiswa lain ada yang mau nanya lagi, silahkan di chat atau boleh langsung raise hand ya. Untuk Suka dan Kim, tadi jawabannya sudah memuaskan atau belum? Kalau belum, silahkan di chat lagi, boleh di bawah ya. Sambil nunggu, saya tunggu 5 menit lagi untuk pertanyaannya. Dr. Aziz, we will wait 5 minutes more for another question. Is it okay?
Okay, sure.
Okay. Well, that's all. While we're waiting, maybe I have my question. I used Sonic Fill back ago, and Sonic Fill now, Sonic Fill 2, does it have any color? I mean, the problem for backfill material is there is color, really translucent color for other backfill material. That's why it's okay for backfill till 5 mm to like cure for first time. And so how is Sonic Fill? Is there any color? I mean, like A2, A3, or another color, or just one color for Sonic Fill 2?
Yeah, so we have 4 shades for Sonic Fill, A1, A2, A3, and B1.
Oh, it's really cool. And for composite, the layer for layering anterior, how many colors that Care Composite have now?
For harmonize, we have 30 shades.
Oh, it's really a lot.
Yeah, and so we have 3 different opacities. There is a dentine opacity, enamel opacity, and then the incisal opacity.
And for backfill, is it okay to compare with the color modifier from the Care? Care have color modifier like the yellowish and brown for make pit and fissure color. Yes. Is it okay to use it for together with the backfill?
You can use that. Yes.
Okay. Thank you. Mahasiswa lain ada mau yang bertanya lagi? Sebelum saya tutup, ini sangat menarik sekali. Jadi saya ambil kesimpulannya tadi ya. Ini tentang inovasi bahan kedokteran gigi. Jadi kalau kalian masih menggunakan 5th generation, mungkin tadi sudah dijelaskan lebih jelas bahwa 5th generation itu memerlukan kondisi yang sangat moist supaya kolagennya tidak kolaps, sehingga dari Care inovasinya menggunakan universal bonding di mana sangat memungkinkan untuk tidak terjadinya kolagen kolaps, akan tetapi untuk menambah bonding ditambah lagi dengan phosphoric exit pada bagian enamel tadi yang berwarna ungu. Kemudian dengan kompositnya, bahan kompositnya yang inovasi yang terbaru adalah sonic fill, di mana sonic fill punya Care sudah 4 warna ya. Jadi tidak problem dengan masalah, karena biasanya backfill itu sangat translucent gitu. Kemudian tadi sudah banyak sekali tip-tip dalam praktek kedokteran gigi ya, mungkin tadi sudah sangat dijelaskan dengan baik sekali. Dr. Asisodi, I think that's all. There's no other question. Do you have any closing statement or something before we close the seminar?
Just that the questions were very, I think, very interesting and very good questions. If there are any further questions that you may have, you can reach out to our team, and also any questions on the products, you can reach out to our team, and I can also support in answering any additional questions that you may have. It was a great experience for me sharing all this.
Thank you so much for the sharing, Dr. Asisodi. It's really interesting. Thank you for your time. And now back to Gracia Jaya Mulia, silahkan.
Ya, terima kasih, Dokter. Thank you, Dr. Asis, for today's great session. This is very interesting. I hope this will be helpful for all of us. Terima kasih juga kepada Universitas Udayana untuk waktu dan kesempatannya. Para dosen yang saya hormati sebagai tim pengajar, semoga acara ini dapat dilakukan secara reguler mungkin Dok ke depannya. Dan terima kasih untuk para mahasiswa yang sudah hadir dan pertanyaan-pertanyaan yang sudah diajukan. Pertanyaannya sangat bagus-bagus, sangat menarik dan menambah pengetahuan juga untuk yang lainnya. Terima kasih Dokter.
Sama-sama, ini sudah kita langsung tutup, langsung diakhiri.
Ya, boleh Dok, kalau sudah tidak ada pertanyaan lagi, boleh kita akhiri.
Oke, terima kasih waktunya ya.
Terima kasih banyak Dokter.
Terima kasih, ini sangat menarik sekali loh. Saya sudah lama ketemu Care. Oke.
Terima kasih banyak Dokter.
Terima kasih.
Mungkin kedepannya boleh dilakukan secara reguler Dok, mungkin untuk mahasiswa
boleh.
berikutnya.
Boleh. Sangat bisa, nanti langsung dengan Dokter Ratna aja. Kita gampang lah.
Baik.
Lagi. Kalau apalagi ada yang baru-baru, mungkin kayak tadi yang ini ya, polishing stripnya rasanya tadi belum dimasukkan, padahal itu sangat menarik sekali. Kan polishingnya sudah ada tuh yang optidisnya.
Bagaimana? Maaf Dok, agak putus.
Yang punya Care itu selain ada polishing disc, kan ada polishing strip itu.
Oh, optidis ya. Ada oklubras, ya Dok ya?
Iya, optidis. Kan ada polishing stripnya kan juga ada punyanya Care. Kemudian demi ultranya juga sangat menarik sekali. Mungkin nanti lain kali kita buat acara bareng lagi ya.
Baik, siap Dok, kami tunggu.
Oke. Baik, kepada mahasiswa seminar saya tutup. Silakan meninggalkan ruangan. Terima kasih atas atensinya. Semoga ilmu yang hari ini dapat sangat bermanfaat buat kalian semua ya. Selamat siang semuanya.
Selamat siang Dokter, terima kasih.